So now I want to call on for Dr. Torres to give the medical management of polycystic liver disease. Vicente. Yeah. So,
Thank you, York, and thank you, Dr. Khalili, for the kind words. And I'm sorry for the delay. Oops. So I'm not going to talk about the ADPLD versus PLD associated with ADPKD because they are very similar. The management is the same. So just the origin of the hepatic cysts. The hepatic cysts have two different origins. One is dilation of the microhematomas or proliferation of intraocular ductules that become large and grow and separate and become cysts. And the other one is dilatation of peribiliary glands. And these peribiliary glands, when they are dilated, they can compress the bile ducts and they can be cause irregularity of the bile duct that sometimes can be confused with sclerosing cholangitis or sometimes even with bile duct stones. So these are examples of the cysts that are derived from the biliary microhematomas that are separate from the bile ducts. And these are the cysts that are closely associated with the bile ducts and that derive from the peribiliary glands. Sometimes they can look like a string of beads. Now, the pathogenesis or the pathophysiology of the polycystic liver disease is somewhat similar to that of polycystic kidney disease, but of course, with vasopressin not playing a major role. But cyclic AMP and protein kinase A signaling and activation of a lot of downstream signaling pathways is also important in polycystic liver disease, causing cell proliferation and enlargement of the cysts. And also fluid secretion, again with cyclic AMP activating CFTR and also promoting the apical trafficking and activation of another chloride channel, TMEM16, also plays an important role in the pathogenesis of polycystic liver disease. But in polycystic liver disease, in addition to this, estrogens play a major role. And this is because the estrogen receptors, that the two that are nuclear receptors and the G protein couple receptor that is called GPER, that is activated by estrogens, all result in the activation of cyclic AMP formation and proliferation and fluid secretion. But in addition to that, FSH and the gonadotropic stimulating hormone also act on receptors on the liver and cholangiocytes and stimulate fluid secretion, and also the progesterone receptors in bile duct ligated mice induce activation of cyclic AMP and protein cell proliferation and fluid secretion. Now, so because of this, it's not strange that you have already heard from York, women, sex is more important than genotype in determining the severity of polycystic liver disease. So yes, patients that have PKD1 truncated mutation may tend to have a slightly more severe polycystic liver disease, but the difference between different genotypes is much less than the difference that there is between women and men in terms of the severity of polycystic liver disease. Of the close to 200 patients that Dave Nagorny did surgery at Mayo for severe polycystic liver disease, over 90% of them were women and only a few were men. And that shows that the rate of growth of the polycystic livers is greater in females than in males, but particularly is greater in premenopausal women, and then goes down during after menopause. Whereas in males, actually tends to go up after age 48. It doesn't slow down in males, and that's shown down here in this graph, where you can see that the females the polycystic liver increases until around age 48, and then in some of them go down and go in decreases. So actually, after menopause, about 1/3 of the livers decreases in females with polycystic liver disease. About 1/3 stays the same, and about 1/3 may grow a little bit more, but not as much as it was growing before menopause. In men, however, the few that have severe polycystic liver disease, the polycystic liver disease does not stop, continues growing all the time. Now, in terms of the symptoms of polycystic liver disease, well, first, the patient with polycystic liver disease, with polycystic kidney disease, should be informed about the status of the liver. In some cases, will be very mild, or maybe in young patients even absent, but in some patients may be severe. So the first time a patient is diagnosed with ADPKD should be informed about the status of the liver. Most patients with polycystic liver disease have no symptoms, and many of them will never develop symptoms. And hepatocellular function remains normal almost even in the most severe cases. Only very, very rarely at the very end with very massive enlargement, you can have some defect in the polycystic liver. As you already heard, the symptoms of polycystic liver disease relate mostly to the hepatomegaly, to the enlargement of the kidney, and maybe pressure against the diaphragm and the lungs, can be pressure on the stomach and digestive system, or can be just abdominal fullness with limited mobility, fatigue, and other concerns, and mechanical back pain because of the weight that you carry in front. So there are other symptoms related to complications that I will leave for the end. So one thing that is frequently not realized is that the enlargement of the polycystic livers in patients with polycystic kidney disease is not just due to the cysts. The hepatic parenchyma is increased, so they have more liver tissue than normal liver. So it's not just the enlargement produced by the cyst. And patients with polycystic kidney disease have hypertrophy of the hepatocytes. We have shown that to be the case in the PKD1 RCRC model. The size of the hepatocytes in the PKD1 RCRC model are larger than normal, and the livers of the in the PKD of the mice with RCRC model have larger livers, even without cysts, just with microhamartomas. So that's important to realize. Now, there are many classifications of polycystic liver disease. One classification is based on the hepatomegaly, basically the number of cysts and the liver volume. And these are the three classifications shown here. These classifications are not very helpful because they don't take into account the age of the patients. So they are not adjusted for age. So that's different from the kidney classification, for example, Mayo image classification. Other classifications are based on the rate of growth of the liver, or the rate of growth of the cystic volume. And these are the CIRCs and the type A classifications. These classifications are more helpful because they give you the rate of growth of the liver, that on which basis you can select patients for clinical trials, or if there was a treatment effective for polycystic liver disease, to enroll in the treatment. And also in terms of the cyst volume, the percent increase in cyst volume is higher than the percent increase in liver volume. So in terms of sensitivity of finding an effect of a drug on the disease, cystic liver volume is more sensitive than liver volume. So because of this reason, the classification by B may be the most helpful as an endpoint for clinical trials. Now, the classification you already heard for is a different classification that is based on the anatomy of the liver, and is a very useful classifications for selecting the right treatment for the patients. You already have heard that from Dr. Khalili. So the Schnelldorfer classification is the best because taking into account not only and the reserve of the good liver parenchyma that's still there, but takes into account the efferent and the efferent vasculature that needs to be patented in order to be able to have these resections that you have already heard, so I'm not going to spend time on this. This you have also seen images similar to that, so type A, B, C, and D help you to select whether a patient is a candidate for cis fenestration or foam sclerotherapy for type B, or in the case of type C for combined liver resection, cis fenestration, and in case of type D for liver transplantation. Now, in terms of a medical treatment, the only thing that we have available are somatostatin analogs. And the somatostatin analogs, oops, I can go back one, or, oh yeah, here, come back one. So the somatostatin analogs work by acting on the G protein couple receptor, that is inhibitory receptor, which are the somatostatin analogs, reducing cyclic AMP, and through reducing cyclic AMP and protein kinase activity, reducing cell proliferation and fluid secretion. And also very important, somatostatin analogs reduce the production of IGF-1, and IGF-1 probably is very important in the pathogenesis of polycystic liver disease. Now, there have been a number of clinical trials with somatostatin analogs, mainly from the Netherlands, and Dr. Hogan and Mayo, and from Bergamo in Italy, and all of them have given exactly the same results: consistent efficacy of somatostatin analogs in causing a reduction in the liver volume and slowing down further progression. This is the study from Dr. Hogan. The first year of the study was double-blind and randomized. And during this first year of the study, the liver volume decreased in the patients treated with octreotide by about 6%, whereas the liver volume continued to increase in the patients not treated with octreotide. During the second year, all the patients went active treatment, and the patients that were treated with placebo before the liver volume started going down, and the patients that had been treated with octreotide, there was a slight further decrease, but not as much as during the first year. And some of these patients were continued to be treated in open label extension. And now this is a selected population because only 21 of the 40-some patients continue to be treated for 4 years. So there is a bias, a selection bias here. But many of these patients have had continued improvement of the liver volume, with the best one after 4 years having a reduction of about 32% of the liver volume. But it's not only that they had a reduction, it's they didn't have further growth. So the drugs, somatostatin analogs, are clearly effective in the treatment of polycystic liver disease. This slide shows that the benefit is mostly in the premenopausal women, because these are the patients where the polycystic liver is growing the fastest. So that's the patients who benefit the most of the treatment. Now, this is another clinical trial which is ongoing. It's the multi-center trial, and Dr. Hogan is participating in it, and it's the Positano clinical trial, which is a new formulation of octreotide, where the administration is subcutaneous, either every week or every other week. So it will be much easier for the patients. The octreotide and the depot has to be given by intramuscular injection, which is painful. This one is subcutaneous, will be easier to use. But most importantly, is the somatostatin analogs have not been approved by regulatory agencies in the United States, because there has been not a clinical trial that has been approved by the FDA and gone through the regulatory steps that they have to go to in order to get the indication. Whereas this trial is going through the FDA. So if this trial proves successful, probably the FDA will approve the drug, which will change the indication in the United States and will facilitate getting the drug reimbursed, which right now is an uphill battle to give in the United States. I think in Europe, and probably in Canada is not a problem, but is a problem in the United States. So based on this, KDIGO, that going to appear in 2025, recommends prescribing long-acting somatostatin analogs in people with ADPKD and markedly enlarged polycystic livers with severe volume-related symptoms. Now, somatostatin analogs can be used in severe polycystic liver disease when there are no, when the other treatments are not indicated or feasible, mainly surgical treatments. Can also be used in combination to complement other therapies, and also it can be used in after surgical combined cyst fenestration, surgical resection, partial resection, cyst fenestration in patients where you have significant amount of cysts left behind, particularly if it's a young woman that has potential for further growth. You can use somatostatin analogs to slow down this process or avoid this process. One of the reasons why you have very good results from this, from Dr. Nagorny's surgery in these patients is because most of the patients who had this surgery were women in their 40s or late 40s, very close to menopause. So they were, after the surgery, were entering menopause, and that also helped a lot to slow down the progression of the disease. That's an example of a combined octreotide. I know form of sclerotherapy is going to be discussed later, but that's a case that is very nice because the patient that I saw when he was 65 years old had a massive liver enlargement with no preservation of any sector or segment of the liver, and therefore was either a candidate for nothing or for liver transplantation. And we decided to treat him with octreotide and with foam sclerotherapy. So this patient has had 7 sessions of foam sclerotherapy. The total liver volume has gone down from 9,000 to 902 and has been treated with octreotide almost all the time with this. So this patient really has avoided the liver transplantation with the treatment with a combined foam sclerotherapy and octreotide. One interesting thing on this patient is that the kidneys continue to grow, but after a number of years, the growth has stopped. So when we talk about octreotide, we say that doesn't work in polycystic kidney disease. And I have some doubts about that. And the doubts I have about that is that the trials, the longest trial in the Netherlands was 2.5 years. And one thing that promotes the growth of the polycystic kidneys and polycystic livers is IGF-1. And IGF-1 is very important for compensatory hypertrophy in the kidneys. So you inhibit IGF-1, you inhibit a little bit compensatory hypertrophy of the kidneys, which is important in the progression of polycystic kidney disease. So in order to be able to see a benefit on the kidneys in polycystic kidney disease, you may need to wait much longer than 2.5 years. So that's what I think that this may suggest, that it's difficult to make a case out of one case, but may suggest that actually octreotide may work in polycystic kidney disease if you wait long enough. Now, somatostatin analogs have some adverse effects. One is cramping, diarrhea, rarely, very rarely steatorrhea, but you have to watch for vitamin K levels or INRs and vitamin D levels, so you have to watch that. Gallstones, cholangitis, pancreatitis can occur rarely. Bradycardia can occur, so if patient, we usually do an EKG before starting somatostatin analog. In the group from the Netherlands has found that patients that we treated with lanreotide, which is one somatostatin analog, may have an increased risk of cyst infections, but they observe this only in patients that have had cyst infections previously, so that increase the risk of recurrence, and then hyperglycemia and another side effect, but that's very, very minimal with octreotide and with lanreotide. With another somatostatin analog that also works in terms of the liver volume, pasireotide, but pasireotide we don't use anymore because it has a high risk for hyperglycemia and developing diabetes. So polycystic liver disease, more severe in women, so there are special things about the management. So in the women develops earlier, is more severe, and so one should very carefully consider the benefits and risks of hormonal therapy. So in terms of contraception, if the polycystic liver disease is absent or mild, these are some suggestions that are going to be also in the KDIGO guidelines. Then combined low estrogen progestin contraception is fine. If the polycystic liver disease severity is moderate, then progestin-only IUDs are likely safe. Don't know for sure because there are no data, but probably likely safe. If it's severe, then probably no estrogen is safe or no progesterone-derived molecule is safe. So in this case, when the disease is severe, barrier-based or copper IUDs probably are the best, the safest. Now, in terms of postmenopausal estrogen replacement, a study from the University of Colorado some time ago showed that when patients that have polycystic liver disease that have estrogen replacement therapy, the polycystic livers continue to grow, whereas in those that don't have a replacement therapy, the polycystic livers don't grow or get smaller. So the question is, if the estrogens are that bad for polycystic liver disease, should the patients with severe polycystic liver disease try to get a therapy that suppresses the estrogen effect? In terms of directly of suppressing estrogen effect, you could use kind of a estrogen receptor degrader or an estrogen receptor modulator, or you could use as an activator or of the gonadotropin releasing hormone or an antagonist of the gonadotropin releasing hormone. In terms of estrogen repressor degraders, there is one called fulvestrant that is available, but there is, I believe, is very expensive and no data available on that. Tamoxifen, as estrogen receptor modulator, has different results depending on the tissue. It's useful in cancer of the breast in some patients that are estrogen receptor positive, but in some other tissues it can stimulate proliferation. So tamoxifen has some pros and cons. So the gonadotropin releasing hormone antagonists are very expensive and not readily available. But there is a gonadotropin release hormone activator that causes initial activation, but they causes suppression of the receptor by desensitization. That is leuprolin and leuprolin, I think, in the United States. And there is a clinical trial ongoing in the Netherlands in using this compound. So that's the trial is the against polycystic liver disease study. The patients are selected to have severe polycystic liver disease. They are premenopausal, and they have proven ongoing growth. And they have a very interesting clinical trial design. So the half of the patients receive placebo during 1 year. But this half of the patients that receive placebo during 1 year then are switched to active treatment, and the primary endpoint is comparing the rate of growth of the liver before being treated and after being treated, and the liver growth between the two groups. So that's, I think, will be a very interesting clinical trial once we have the result. The outcomes, of course, are liver growth, adverse effects, and patient-reported outcomes. Now, there are other drugs that have been tested for polycystic liver disease. A retrospective study by Dr. Shane and Mayo in patients that have been transplanted with a very small number of patients showed that sirolimus and reduced the rate of growth of polycystic livers, whereas the patients treated with tacrolimus after transplantation have continued growth. This has not been confirmed or disproven later on, so that's still question pending. There is a trial from the Netherlands where they compare octreotide alone versus octreotide plus everolimus, and everolimus did not add anything to the octreotide. So in the presence of octreotide, it seems that the everolimus didn't work. And then there is ursodeoxycholic acid, a trial using ursodeoxycholic acid that have been shown to help or to be effective in animals. The trial was negative in patients with polycystic liver disease, although the sample was quite small, but the results were going in the wrong direction, so it doesn't seem that ursodeoxycholic acid was beneficial. And there are many other drugs that have been shown to be effective in animal models, but none of them has yet moved into clinical trial. So in terms of the complications of polycystic liver disease, you have them listed here and include mostly cyst infections and hemorrhage and compression of other structures. In terms of cyst infection, you suspect it in the presence of the triad of fever, abdominal pain, and either high CRP or white blood cell count. The diagnosis has to be based on having at least 2 positive findings of the other criteria, which include clinical factors and microbiology and imaging. And when there is a cyst infection, then you have to treat with antibiotics that have good penetration into the cyst. So ciprofloxacin, for example, has good penetration, and the treatment has to be prolonged for 4 to 6 weeks. And if there is not an early response, then sometimes it's important to have a drainage of the cyst in addition to the antibiotic therapy when that's the case. There's another therapy that has been suggested is selective, well, some patients who have liver cyst infections, when the isolated liver cyst infection is not a problem. However, there are patients that have very recurrent liver cyst infections that are very difficult to treat, very frustrating, because they are treated multiple times and have episodes, recurrences of cyst infections several times a year. And these are very frustrating patients to treat. And in these cases, the treatment that is usually that we use usually is cycling antibiotics. So we treat these patients for 1 month with ciprofloxacin, another month for Septra, another month with doxycycline, and cycling antibiotics to prevent having resistance developing. But another technique that has been suggested from the group in Nijmegen in the Netherlands is selective decontamination of the digestive system with polymyxin plus minus neomycin. And they have a small group of patients where this approach has been successful in the majority of patients, however, with significant complications when using neomycin. So that's not a perfect treatment, but something maybe in desperate cases that one can use. In terms of the complications of polycystic liver disease, in terms of medical therapy, one thing which is important to remember is that 40% of patients with polycystic liver disease have a dilatation of the intrahepatic bile ducts. This leads sometimes to doing ERCPs and sphincterotomies, and that's one thing that should not be done. It should be avoided because patients with polycystic liver disease that have sphincterotomies, they very frequently after this have recurrent episodes of ascending cholangitis, which become a nightmare. So sphincterectomy is something that should not be done in polycystic liver patients unless it's unavoidable. Some cases may be unavoidable. This is in terms of the frequency of common bile duct dilatation that occurs in about 40% of the patients. And then hepatic venous outflow obstruction is another complication of polycystic liver disease. And we see that particularly in patients that have very large polycystic kidneys and undergo bilateral nephrectomy and also have a severe polycystic kidneys. When the polycystic liver and when you have big polycystic kidneys, it's resting on the polycystic kidneys. You take the kidneys out, there is some shifting of the liver, and this can cause some kinking of the hepatic veins, and that results in hepatic venous outflow obstruction with the production of ascites. And this ascites may be very difficult to control. In these patients, sometimes what you need to do is to do a hepatic venogram, measure pressures across the area of narrowing of the vein, and if the pressure gradient is demonstrated, then placement of hepatic vein stents, and that usually works. And sometimes also treatment with somatostatin can help in addition to diuretics to control the ascites. And these are examples of thrombosis. That sometimes the hepatic venous outflow obstruction can be complicated by thrombosis. When it's chronic, can be complicated by fibrosis and development of cirrhosis. So that's. And then the other complication is portal venous compression by hepatic cysts, which may result in portal hypertension. That again requires stenting. And then finally is IVC compression, but large polycystic liver cysts, which sometimes can be complicated by IVC thrombosis. And again, that is requires a stenting of the IVC. And that just shows an example of that. And I think that's all about the medical management of polycystic liver disease. Thank you for your attention.